Hey everyone, welcome back on another Shakti mat session today in quite some pain because I just started. So I want to talk about what I am afraid of if I'm not afraid of death. So let's get to it. It's a journey that everyone only takes once in this life, and it's a journey that nobody really knows for sure what it's like until they're actually taking it. You can get a pretty up close and personal look, but it will never be firsthand experience. So, and that's part of why death and dying is so scary sometimes, is the unknown. And as I have described in my previous video about near death experience, specifically my own near death experience, I mentioned that I was no longer afraid of the idea of dying. But that doesn't mean that I'm completely fearless and I'm not afraid of anything at all whatsoever. No, that's not true, because without fear, we will be we would make very irresponsible choices for ourselves, and that's not good. So what am I afraid of? I'm afraid of the pain and the suffering that can accompany death, or the process of dying and reaching that point. I am also afraid of suffering for the sake of suffering, so needless, unnecessary suffering. And I try to anticipate and avoid getting in situations where I might suffer such things. Of course, you can't predict every single thing in life, but that's what I would be most concerned about for myself at end of life. So, in my role as a palliative care physician inside the hospital, I take care of a lot of folks. Some are actively dying, but many who are not. But a lot of times when I am involved in a patient's care, one of the major things I help take care of is actually symptom management and relief of suffering as a palliative care physician. Before I get to the medical, physical ways where I help people avoid suffering and pain and relieve their suffering and pain, I want to talk about non medical interventions that can help people with just easing their burden of going through their critical illness or their severe illness, their chronic illness, exacerbations, things like that. And that's by providing active listening. I cannot understate how much people feel that they don't get listened to in, especially in the hospital setting, but in healthcare in general, where they're so used to doctors that come in for 3 to 5 minutes and talk to them instead of listening to them. They talk to them, tell them what the doctor thinks they need to know, and the doctor then leaves the room. And so it gives the impression that, hey, you just wanted to tell me things so that you check your own check boxes and so you could leave and move on to the next patient. And in reality, yeah, that's basically how modern doctoring works, is you have to see so many patients and you have a limited number of minutes that you can spend with each patient before you get bogged down and you have to stay late and you have to finish your notes when everyone else has gone home, or worse, you have to take your work home. So no doctor really practically wants to do that, and that's why they have to prioritize their time, which means the patients end up getting less time and they get less empathic and compassionate listening. So, one of the things I offer is I listen to people for a living, and that by itself, I've been told by many people, not everyone, but many people, that by just having a conversation and just talking to them like they're a human being helped them feel so much better about the situation that they were in. It didn't like physically change the situation that they were in, but it provided some reassurance and some stability. It sort of acts like a mental anchor that, hey, when Dr. Pan comes in, you know he's going to listen to you. He's going to spend some time. He's going to sit down and listen to you, and he's going to bounce ideas back and forth with you. He's not going to just do a one-sided conversation and then leave the room without you having said your piece. And so that's one of the first and easiest ways that I help people with pain and suffering, is provide that emotional release, so to speak, that emotional support. And my entire team does that. My social worker also does that. Our chaplain, they do that as well. And so we provide that sort of invisible benefit that can't really be measured by any sort of standard metrics, right? Unless you give someone a survey that says, "Hey, how did this encounter make you feel with this person?" You don't really know, because it's not something that's objectively tracked as an outcome, unlike mortality or hospital readmission or whatever things that hospitals tend to track. They don't track what I do with my conversations. So that's the really the easy part that I just do naturally, and it's really enjoyable too, because I don't feel rushed. I have the unique privilege of having a job description where my job is literally to spend time with people because they need it. And that's rare to find in medicine these days when you're on the healthcare provider side. So that's the emotional cycles social part of the encounter that I provide. And then there are the medications that I can use to help with bothersome symptoms. So that is measurable. We have tools that can measure people's pain score, pain levels. I'm sure you've heard of the 0 to 10 scale. There's the FACES scale. There's the nonverbal scale for pain that we use depending on if the person is able to tell us whether they have pain or not, physical pain. And then we have tools that also help us keep track of where the pain is, how does the pain respond to pain medication, what makes the pain better or worse, and what are the associated symptoms with the pain. So all these measurements go in to help us really narrow down what's causing the pain, and therefore which medication is best used for pain. I want to I want to bust a myth that tends to be associated with palliative care and hospice, especially hospice, where sometimes people get the idea, oh, palliative care and hospice, all they want to do is give me a bunch of morphine and make me die faster. And that couldn't be further from the truth. In general, doctors in the United States these days are super duper cautious with opioids such as morphine, oxycodone, dilaudid, fentanyl. All these opioids are very scrutinized when they're being used, and they're being used with extreme caution, sometimes with too much caution, in my opinion, to the point where you're under treating people's pain. So it's a notoriously difficult practice to do, is opioid management, because people shy away from it these days. So new trainees are shying away from pain medication. So the art of treating people's pain, the science and the art of treating people's pain, is unfortunately, I think, diminishing amongst new doctors. And that especially puts palliative care physicians like myself in a very unique situation to help with pain management, because we treat people on a daily basis for with pain. But that doesn't mean that opioids are the only pain medication we use. So we still follow the appropriate use of opioids, which is to avoid, of pain medication, which is actually to avoid opioids when we can and to use the minimum amount of opioids if we have to use them whenever we do use them. So we also still start with Tylenol if the pain is not too bad, for example. We also think of where the pain is coming from and how to best treat the pain, because not all pain is created equal. And some pain don't really respond that well to opioids, believe it or not. Nerve pain in particular is one that we pay especially close attention to, where we actually prefer to use non-opioid nerve pain agents, and those things are gabapentin and pregabalin or Lyrica. These are common, actually, diabetic neuropathy pain medication that people get prescribed for diabetic neuropathy. And we use this when we think there is a neurologic or nerve related, we call it neuropathic pain component to the pain. And then there are also anti-inflammatories like non-steroidal anti-inflammatory drugs like NSAIDs, like ibuprofen, Aleve, naproxen, celecoxib, and steroids. Even the steroid are anti-inflammatories. So when there's an abundant of an inflammatory condition, we sometimes think of steroids and NSAIDs to try to help decrease that inflammation without resorting to opioids. And then there are opioids. Opioids come in many shapes and forms. There are pills, liquids, patches, uh, injections, and sometimes even patches that you can put in your mouth, buccal patches. They also, fun fact, used to make lollipop fentanyl formulations, but those have since been discontinued because of dangers to children. So when we take care of people, we look at their pain, and that's how we help address physical pain. Usually we use a multitude of pain medications in our arsenal, and 99% of the time we can get people's pain under pretty good control. It's not 100% because there will always be people where we try everything and nothing works. And what I find is that in these patients, we have to actually suspect emotional and psychological pain being a large portion of their perceived pain. So there's an idea that has surfaced in recent years, and it's now a more commonly accepted idea that of total pain. So there's physiologic pain that is caused by something actually physically wrong in the body, and such as cancer growing, causing inflammation, causing compression of nerves, just generally causing irritation of tissue that then sends receptors, the chemical signaling molecules, to the receptors to tell the brain, hey, there's pain. But then we also started to recognize psychosocial emotional pain as amplifiers of that physiologic pain. So when people are extremely depressed and they're extremely anxious, I should say, and or their pain can actually be amplified significantly to the point where you can throw all the opioids you want at that person and nothing really takes care of the pain to the extent that they are comfortable. Not zero pain, I'm talking about just tolerable pain. So their pain can be always just intolerable. And that's a very challenging area, and I don't think, honestly, I haven't seen anyone truly manage total pain with complete success every single time. It requires a lot of multimodal approach, such as counseling and usage of antidepressant, anti-anxiety medications to keep their mood under control, as well as treating their real, quote unquote, real pain at the same time. So total pain is one of the worst pains that I've dealt with, and that usually is something that I have to deal with once every few weeks. It's not too common, so once every few weeks I personally bump into someone whose pain is really, really bad because they have, on top of their real pain, such as cancer, they have emotional burden behind that pain, and that makes it very, very troubling for both the patient and really myself. It becomes very frustrating for everyone involved that the pain is never well controlled. There's another reason why pain medications can be ineffective, especially opioids. So there are genetic variations amongst all of us and amongst the races, actually. Uh, some races do not metabolize opioids as well as others, and some are fast metabolizers. So that means opioids may not be converted to their active pain relieving forms inside the body as effectively for some people, or the body gets rid of the pain medication much faster and metabolizes and digests the pain medication so it's out of the system sooner than the drug makers and the scientists have, who study the drug and came up with the every few hours you take this much pain medication. They outpace that schedule, so they actually need more frequent dosing or higher doses, or to just change to another opioid medication that works better for them and their receptors. So these are the complex considerations that goes on in my head when I treat people for pain. And that's why there's a specialist level of palliative care where the normal generalist pain management is just not enough. So that gets me thinking, when it's my turn, when I'm lying on that deathbed and I'm suffering, I hope that at that point there will be someone who is skilled enough to relieve my suffering so that I'm not lying there and struggling and suffering for no reason, when the pain could be much better managed. Another symptom that I also take care of is trouble breathing. And trouble breathing can come in various different forms. There's end stage pulmonary disease, COPD. There are heart failure related issues where the lungs kind of swell up with water. There's cancer physically taking up space in the lungs. There's other types of diseases that replace healthy lung tissue with abnormal tissue, so air exchange becomes inefficient. Just to name a few ways that people can experience trouble breathing. And trouble breathing is perhaps one of those things that I think everyone fears to a certain extent, because I hear that we don't want to choke, we don't want to suffocate, we don't want to feel like we're drowning. These are very common concerns from people who have issues related to end stage lung or end stage heart disease, where they experience a lot of trouble breathing. And end stage kidney disease, actually, because fluid can build up in those scenarios. So how do we take care of trouble breathing? Well, I think if there are medications such as inhalers for lung disease that the person can take, I still encourage them to take these inhalers, because that keeps the lungs working as best as possible at baseline. If there are water medication, diuretics like Lasix, that someone can take for volume overload, too much fluid, to relieve their heart so they're not working as hard, their lungs are not filling up and swelling with fluid. I advise people to continue taking those as long as it's suitable and appropriate and they can take the medication. But when push comes to shove, when someone is truly at the last few hours, few days of their lives, and they can't take any medications by mouth anymore, we resort again to opioids. So, opioids have this side effect. It's not an adverse effect. It, for me, is a bonus side effect of telling a part of our brain that really freaks out and rings up the red alarm saying, I can't breathe, panic, 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 panic. It tells that part of the brain to relax and calm down a little bit. And so we don't mind as much. We don't pay as much attention to, hey, the body's not getting enough oxygen, the body's not expelling enough carbon dioxide. That part of the brain is muted with opioids, with the help of opioids. And we can actually see, for even people who are not terminal, but people with end stage lung disease, COPD, by giving them small amounts of opioids, studies have shown that they actually end up using less oxygen. And when they use less oxygen because they're panicking less, their heart is not beating as fast, their whole body uses less oxygen, their breathing actually improves. And sometimes their oxygen levels can actually improve too for a short period of time when taking opioids. There are also things like medications that help dry things up if the lungs are wet, if there's a lot of secretions in the mouth, in the throat that a person cannot manage, and there's the sensation of choking. We can give medications that help dry things up in the lungs, in the throat, in the mouth, so that there's not as much of that fluid feeling of drowning, which is a big deal. It's huge. And people do think about these things, and doctors such as myself do think about these things to help my patients avoid situations where that's happening. And of course, there's always oxygen, supplemental oxygen that can also help. Surprisingly, one of the most effective ways to help people feel like they're breathing better is by blowing wind on their face. So I always recommend, when possible, to have a personal sized fan to blow air, a strong current of continuous air blowing on the face. There's a physiologic reflex uh, that our face has, the receptors in our face, when it feels wind, it gives us a sensation that we are getting more air. It tells our brain, it fools our brain into thinking, hey, we're getting more air and we're breathing better than we actually are. So these are tricks that we use to help the brain relax. And then other bothersome symptoms, anxiety. Anxiety, when it gets out of control, out of hand, it becomes very distressing for the person, but also for family around the person, family and friends around the person to witness. So we also help control that with medication and non-medication techniques. So things like minimizing interruptions, minimizing vital sign taking, minimizing blood draws, that can help with a lot with anxiety without using medication. At end of life, we are much more liberal with anxiety medication, such as benzodiazepines, Ativan, diazepam, are very commonly used to help relieve the anxiety. And that can also cause sedation. So I often tell people, overall, when I'm managing all of these symptoms, pain, difficulty breathing, anxiety, those are the big ones, that when we use all of these medications together, there's a good possibility that it will make the person very sleepy and make them very hard to wake. And I also tell people that there may be times, or there may come a point of time when keeping someone awake without significant suffering becomes near impossible or impossible. And there is really no in between. They're either awake and they're suffering, or they're asleep and they're not suffering. And often when it comes to that, the person is very, very close to dying, usually hours to days. And I tell people's family and the patients themselves, like, hey, heads up, this might happen. And do I have your permission in that case to err on the side of making you too comfortable, but keeping you asleep, rather than allowing you to wake up and experience all the suffering in an intolerable amount? So most people would tell me it's fine, and they would rather not see people suffer. And to that, I say good choice, because I would pick the same thing for myself. So these are concerns that go through my head whenever I have to take care of people during their final moments. And of course, I always put what people want ahead of my own wishes. I don't just project what I would want for myself onto my patients. I clearly outline what I would anticipate, what my experience has been taking care of people, and I allow them to choose, with my recommendation, of course, whether how aggressively they want me to manage their pain and keep the suffering to a minimum. So that's what I'm afraid of: pain, suffering, and that's why I take great pride and great care when I'm tasked with relieving people's pain and suffering. It is such an important thing to me. And for me personally, as a doctor, when I signed up to be a doctor, I really, really wanted to just help people. And nowadays, that's my idea of how to help people. So that was quite a long-winded way of describing my job, but hopefully that clears things up in terms of, just because I'm not afraid of death and dying for myself anymore does not mean that I don't have any fear. But the fear that I have now can be mitigated with, usually successfully, with high success, with medications and techniques that we practice in medicine today. There's no point for me to worry about things that I can't control, but if these things are within my control to a degree, I would want them to be controlled, or at least by the team that's taking care of me. And so, if anything, this serves as a video telling people, hey, I do not want to suffer if I am dying. Just let me be comfortable and let me embrace the beyond. All right, so I am just about done with the Shakti mat. I might do another video depending on if I want to go to an hour or not, but this will be it for this episode. Thanks for joining me. I really appreciate people tuning in and watching and listening and leaving comments and telling me their thoughts. It really means a great deal to me. I know there's only a handful of people, just a few people, over a dozen right now, but still, you guys are the OGs. I really appreciate you coming to my channel, watching my videos. It really gives me the drive to make more videos going forward. And I hope these videos do give you some insight, just as they help me go through my life on a daily basis as a palliative care doctor. And what to look forward to in the future, I hope that I am able to continue providing insight from a palliative care standpoint and from a personal standpoint as a human being, so that it eventually, any of these videos can help somebody. gain more insight and live a better life. So thanks again. I really appreciate you. Love you all. Peace.